All right, so we're going to try and get through the end. It's been a very long day, so it's good to see everybody still paying attention. We're going to talk today about abdominal and pelvic pain. And so these pains can come from a huge number of structures, but because of that, there's actually a lot of things that we as interventionalists can potentially do. So we can look at visceral pain, we can recognize referred pains, we can look at sympathetically mediated pains. I actually think that chronic pancreatitis is a CRPS of the pancreas. There are musculoskeletal pains that will cause both abdominal and pelvic problems. There are neurogenic, and which is obviously the thing I'm the most interested in, being so interested in peripheral nerves. There can be vascular and ischemic issues, and that's certainly one of the things you don't want to miss. There could be cutaneous pain, so things like zoster, where there's sensitivity and allodynia of the skin. There can be metabolic pain, the abdominal pain, for instance, from a porphyria might be difficult to recognize. But when we think about visceral pain, we're going to try and focus on that a bit. That visceral pain is usually described as a deep, dull pain. It's vague, and it radiates away from the organ. For abdominal pain and pelvic pain, there are actually about 4 areas that we have the potential for causing pain, but really only 2 of them in this abdominal region that we pay attention to, the splanchnic and the celiac. So when we look, if you're having pain that's caused by a viscera in the abdominal cavity, that's fine, but you have to also keep in the back of your head that there could be thoracic problems that are referring. And so a thoracic aneurysm can refer to the abdomen. A facet in the thoracic region can refer to the abdomen. An intercostal nerve problem can refer to the abdomen. So you've got to keep that in the back of your mind as well. So we're going to use chronic pancreatitis as the example that we're using for a visceral pain. It is that comes from often chronic alcoholism, though it has many other causes. And what they think happens with the pancreatitis with alcohol is it causes the pancreatic cells to secrete a protein. That protein precipitates in the pancreatic ducts, and that clogs up the ducts, leads to a backup of those enzymatic enzymes. It's probably the same mechanism that we see when there are pancreatic stones or gallstones in the common bile duct. And this causes the obstruction, inflammation, and fibrosis. So with pain control, when we're looking at chronic pancreatitis, you can certainly give opioids, but that won't fix anything. You could do neurolytic blocks, which of both the celiac and splanchnic, which we'll talk about in a minute. An intrapleural injection, which has sort of fallen out of favor, but was really a lot of fun to do. You would put an intrapleural catheter above the rib with the patient in the affected side up, do a loss of resistance syringe filled with saline. You get a loss of resistance when you're in the pleura. Then you have the patient take a breath, hold it, take off the syringe, thread the catheter, pull the needle out, and you would then have them stay on their side while you injected local anesthetic in through the catheter, and it would stay in that posterior sulcus right where the sympathetic chain is, which is why I became convinced that this was a sympathetically mediated problem, because you could anesthetize the sympathetic chain and get remarkable relief. And so I had one gal for 6 months. She gave herself 5 cc's of Marcaine twice a day, and it relieved total of her pain as she came off all her opioids. But because we have better techniques now for the splanchnic and the celiac, that has become our technique of choice. And so here you see the celiac plexus wrapping anteriorly around the aorta. But just to show you, you've got iliohypogastric, the ilioinguinal, here are your ureters, here's the superior hypogastric plexus here, and this whole network of sympathetic nerves that are in the area, as well as the renal plexus that are going around both of the kidneys. So we have this sympathetic chain, the connections with the sympathetic chain to the celiac ganglion and the collection of ganglia here. And so both of these are potential targets for abdominal pain. The celiac plexus was described first in 1914. Splanchnic was described in 1924. So these are not new techniques. But the thing that's made the difference is the ability to do them with fluoroscopy. We did, even when I was doing my residency, we were still doing blind celiac plexus blocks. But now that we have fluoroscopy, it's made the techniques much safer and much easier to do. Indicated for cancer of the upper abdomen and chronic pancreatitis, and you can either use alcohol and phenol for the celiac plexus or radiofrequency for the splanchnics. So when we start looking at the splanchnic nerves, you've actually got several of them. You've got the greater, the lesser, and the least coming through the crura to come into the celiac axis. And so you can do several approaches. You can approach it at T11, the junction of T11 and T12, or at T12, but mostly it's this region that we're focusing on because you have the potential for addressing both of the major nerves there. The third splanchnic being, the least splanchnic being least important. And so here, this is from Andrea, you see the very nice dissection of the splanchnic nerves coming from the celiac, from the sympathetic chain here, going across the discs and the intercostal nerves and coming anteriorly. And here you see, if you have the needle coming across both of these nerves, you can end up lesioning them both at the same time. So the Splanchnic technique recognizes that you have the spine, you're not doing it from a straight AP view, but rather obliquing. And I visualize that in the sympathetic chain that you have in the stellate region, that sympathetic chain lies right on top of the transverse process. And in the thoracic region, it's in the posterior 1/3 of the vertebral body. As we're coming to the splanchnics, it's moving to the anterior 2/3. And then as we get into the lumbar sympathetic, to the anterior lateral portion. And then when we get to the superior hypogastric, we're talking about the anterior. And then it comes completely anterior by the time we get to the ganglion of impar. This ability to oblique allows you to be able to identify where the pleura is and to place the needle as hugging the vertebral body. Here you've got your diaphragm, T12, T11 ribs, and you're coming to the distal 1/3 of the vertebral body. And in a true PA view, then you see that these are just hugging the very lateral aspect of the vertebral body.
Do you see the pleura, Andrea, there?
Where you'll find the pleura will be,
line there.
is this line right here, right there,
Off the,
just off the edge of the transverse process. You don't actually, here, sorry, you see it there. Yeah, there you see it. And you've actually got a fair amount of room there. You don't see it as easily down here, but here I would call that the pleura right there. But as I'll show you in a minute, it's still coming very close to where the pleura is. And this is the lung right there, and here's your needle trajectory, and it's stopping right here, and the contrast is moving anteriorly there. But you can see just how close the lung is, and this is one of the things, one of the times where I think having a blunt curved needle here of all places is something that's really very important. And then you'll see it here from just in the anterior lateral aspect. The celiac plexus is done just a little bit differently. You're talking about coming on, the old technique was to come onto the vertebral body and then walk anteriorly. And the problem with that is that you're hitting on the periosteum, down, da-dun, da-dun, da-dun. And now we recognize that if you do, again, that same concept of obliquing the vertebra, and coming at it anteriorly allows you to be able to get into this in front of the vertebral body, in front of the crura, to where the celiac plexus is. And we recognize that this celiac plexus, which is really anteriorly and wrapping this way, that by putting medicines posteriorly, we can get the medicines to go anteriorly. Now, I actually used to do a transaortic approach. Wonderful way to do it. You know exactly what your landmarks are. You would get blood, advance, advance, advance until you didn't get blood, and then inject your medicine. And that actually, according to my faculty advisor in medical school, was the first cardiothoracic surgeon in South Carolina, and that's how they did their arteriography in the early 20s, they'd inject it transaortically from the upper thoracic region, or the upper abdominal region. They didn't have multiple plates, so they would take X-ray plates and wrap them in a blanket in an accordion style, do a continuous X-ray, and just pull out each of the X-ray tubes. And so what the problem with this posterior approach is severalfold. First of all, you've got to be placing 2 needles, and you've got to go past a lot of structures to get here. The possibility of getting into the kidneys, the pleura, the lung, having medicines track back to the genitofemoral nerve. And you've got a patient who's got terrible abdominal pain, and you're asking them to lay on their stomach for quite a period of time. What is a different technique that you need to think about is an anterior celiac plexus. Under CT, you can see exactly what your track is. Instead of using 40 cc's, you can use 5 cc's of your local and or your neurolytic injections. The patient's perfectly comfortable. You do potentially go through a little bit of bowel. You can see where the liver is, and so you can avoid the liver by going slightly off midline because you can see where it is. And as long as there is not a bowel obstruction where you have fecal material sitting there in the gut, this is a very safe way. And one of the ways, by the way, the radiologists do all their anterior node biopsies is just done like this. And from a 3-dimensional view, what you see is the medicine right there in the anterior portion. Here's the aorta and just anterior to it. Complications are predictable, pneumothorax, especially with the celiac. If the neurolytic local or neurolytic going where you don't want it to go, you can get subarachnoid if you're not recognizing where you are, you're on a nerve root, bleeding, visceral damage. Hypotension and diarrhea, though, are not really complications. They're expected side effects of a sympathetic block to the gut, because it's the sympathetics that cause the blood vessels the gut to slow down. And so when you block that, they'll get diarrhea, and you block the blood vessels, and you'll get pooling of the blood in the gut. Did you need? Okay. All right. The superior hypogastric plexus, you'll get the slides, yeah. The superior hypogastric is the extension then of this sympathetic chain coming anterior to the vertebral body of L5. It was originally described by Riccardo Placante, and if you're at the meeting later this week, you'll get a chance to meet him. He's supposed to be coming. And this was described in the early 1900s, but he started putting it together for these techniques in 2005. And these are his slides. The recognition is that this collection of nerves sits right at the sacral promontory. And it's a lot of loose tissue in this area, and you can fill that potential space with local anesthetic and potentially neurolytics. And so you see this collection of nerves, and on either side, just sort of in the center of the split of the bifurcation. It lies anterior to the 5th vertebral body, and it gives rise to the pelvic, middle rectal, vesical, prostatic, and the uterovaginal plexus. And so it's a very useful technique for pelvic pain. In fact, he sees many, many women in the Mexico City area who come for hundreds of miles to get this injection. He doesn't even do a diagnostic block because there's so little in this area that can cause problems. He just goes straight to the neurolytic. These are used for gynecologic disorders, chronic pelvic inflammatory disease, endometriosis, the non-gynecologic interstitial cystitis, irritable bowel, post-surgical pain, and obviously neoplasms. There are 3 techniques. There's a medial, lateral, and intradiscal. And Aggie did a very good job of showing the difference between the medial direction, the lateral direction, and the lateral direction, and then the transdiscal. And so it's a technique that can be somewhat difficult because it's not a down the barrel technique. It requires you to recognize that you need to be going medially and anteriorly at the same time to get anterior to that vertebral body. And so what's been kind of fun about this, you see that you'll see the medicine in this sort of horn shape, and here anterior to the vertebral body. What was fun was the recognition that we could struggle with the standard superior hypogastric injection, or you could just go straight through the disc and you'd be right there. And so the transdiscal approach has made this procedure so much easier, with the recognition that you want to stay on the far side of the disc. You're trying not to enter into the nucleus pulposus itself, but rather just staying right along the edges. And here you see the direction that you're wanting to go. You can do a single needle or bilateral needles, and it'll put your medicine right here in the hypogastric area, and you see it.
Is there any chance of discitis for this procedure?
Yes, and that's the one downside. And so these patients get IV antibiotics just like doing a discogram. But that's why you stay just on the very lateral edges. You're trying to stay in the annulus and not get into the nucleus itself. But it's a technique that if you do discograms, you simply modify a little bit your angle, and that's the technique for the transdiscal hypogastric. So some practitioners, as I said, don't do any diagnostic injections because there's so little in the area and the low complication rate of the neurolytic from the standard approach. So what you can think about this got in the wrong order. For splanchnic nerve blocks, you're looking at diagnostic for retroperitoneal and upper abdominal and flank pain. So I had a guy who had a gallbladder and had bleeding from the gallbladder, had a lot of right upper quadrant pain postoperatively. Pain went away, he went back to work. The first day he's back at work, he fell and broke the rib right there on the right side and had persistent pain. So the question is that from the surgery or is that a workman's comp injury? So we looked at doing intercostal nerve blocks and then did the splanchnic, and the splanchnic made the pain go away and the intercostal didn't. So it became recognized that it was from the gut. For the pelvic and urogenital pain, there are a tremendous number of structures in this area. About 2.5 million women with a diagnosis of chronic pelvic pain. So there are a lot of women out there, and another 1.8 million with interstitial cystitis and 2 million men with chronic prostatitis. So these are very garbage sorts of diagnoses, and these are the patients that you can potentially help a great deal. The sources of pelvic pain can be reproductive, urinary, GI, musculoskeletal, neurologic, metabolic, psychological. So there are lots of things that are causing pain in these patients. And if you can tease some of that out, you can potentially offer them a good deal of relief. The history, the pain pattern is critical. Your physical exam, things like if they have a limp, well, maybe it's something that's a psoas problem. Are they have the patient point to where it's hurting? Are they having pain where they're standing or supine? These are all clues about where the pain may be coming from. And then, but clearly the diagnostic injections, which we are able to do better than any other specialty. So you've got your abdominal wall pain, which will mimic endometriosis, interstitial cystitis, abdominal adhesions. And the anterior cutaneous nerve entrapment, or acne, which we talked about yesterday when we were doing the physical exam, and the fact that the ilioinguinal iliohypogastric are extensions of that same concept with potentially other areas, the genitofemoral nerve and myofascial trigger points. And abdominal trigger points, and I think that's one of the things that gets forgotten, that these trigger points can cause nausea, vomiting, anorexia, urinary bladder sphincter, dysmenorrhea, so all those things that we thought had to be visceral can be coming from the abdominal wall. And these are just some examples of some of the trigger points. And the iliopsoas is an example. And so abolishment of symptoms with local anesthetic strongly suggests abdominal wall origins of pain. Then we move a little bit further down into the sacral nerves. We've got the sacral neuralgia from the posterior branches being the medial cluneal or the lateral branches of the sacral nerves. So they can cause sacroiliac pain, coccygynia, or a variety of pelvic pains. So from a fluoroscopic point of view, you have and you can see this person had lots of clips in the area. You've got your sacral hiatus for the caudal, the sacral foramen here, the posterior rami, which would be the middle cluneals or the lateral branches. You have the S5 nerve root coming out on either side of the sacral cornu, which can cause pain going into the coccyx region, the sacrococcygeal joint, the tip of the coccyx. Here you see the sacroiliac joint, the edge, the sacrotuberous ligament, and the sacrospinatus ligaments. So you've got your sacral nerves coming anteriorly, and then making up the sciatic nerve and the pudendal nerve. You have the sacral nerves posteriorly innervating the SI. You've got your sacral nerve root itself. You can look at caudal epidurals. And this is often my first approach to somebody with pelvic pain that I can't figure out what the problem is. I'll do a low volume, low dose local anesthetic and then examine them, because most of the time before you do that, you just can't touch them. If the local anesthetic makes the pain go away temporarily, then I know that it's not genitofemoral, ilioinguinal, one of the pathologies that may be cephalad, but instead it's in this sacral region. So it allows me to very quickly and safely separate those two. Caudal neuroplasty allows us to be able to recognize that adhesions in the lumbar and sacral region can cause problems with the sacral nerve roots. And then the pudendal nerve, and we've talked about the pudendal nerve a couple of times already, but it's a very important nerve because it can cause perineal, vaginal, perirectal, coccydynia, mimic interstitial cystitis, and prostatitis. And so it comes from underneath the piriformis, over the sacrospinatus, under the sacrotuberous, and then has a long path. But the recognition is after it crosses over through Alcock's Canal, it starts to divide into a variety of branches, and that allows you along this pubic ramus to individually pick out individual branches. So you see the path here coming under the piriformis, over the sacrospinatus, under the sacrotuberous, and through Adcock's Canal. Here you see the nerve passing through Adcock's Canal. Here, the obturator internal muscle, the symphysis pubis here, and the sacrotuberous and sacrospinatus ligaments. So there are several places where there could be injured: sacrospinous, sacrotuberous, the falciform process, which is that very broad attachment of the sacrotuberous ligament onto the sacrum, onto the ischium, at the ischial spine, the piriformis sacrotuberous ligament, obturator fascia, and 70% of the patients will have only a unilateral entrapment.
Does it also help in pelvic trauma?
It can be traumatized in pelvic trauma, and so it can help diagnose a cause of pelvic pain after a pelvic trauma. You can do injections along the inferior pubic ramus to pick off the individual branches. You could do cryo at the ischial spine, though only do one side, don't do bilateral for that because you'll lose too much in the way of pudendal sensation. And then you can do cryo at Adcock's Canal or anywhere along the path there. Don't forget the pelvic floor muscles. They can cause a tremendous amount of pain. So here you have the obturator internus, the piriformis muscle, the coccygeus, and then the levator ani, which is actually several muscles that are combined together. We go on down to the end of the tailbone. You've got the sacrococcygeal joint and ligament, and then the ganglia of Impar, the ganglia of Walther, which is usually a fused ganglion, so you see them coming anterior, and then fuse. Your target is right here, and again, I'm dating myself, but I remember when we would try and do these with bent needles to try and get up underneath the edge of the sacrum and then getting it back the other direction. And once again, it was one of those things, well, why are we making something difficult out of something easy? Because we now recognize that all you have to do is go straight through the sacrococcygeal ligament right there, and you're right there. It becomes the easiest procedure you can imagine and can be very, very useful. And then we talked about stimulation. We talked about doing for genitofemoral, for instance. You can have a lateral aspect when you're doing interstim. This is a technique where you take a tined electrode with little spikes on it, through the sacrum. Through the sacral hiatus, through the sacral foramen. I'm going to encourage you to work with your urologist. They don't know how to do this percutaneously, so they have to cut down to do it. And I think being able to trial these patients without having to do a cut down would be a remarkable thing for helping the patients before they got committed to this. Retrograde, passing down the nerve roots. This, by the way, was a patient who had an interstim, and it didn't help because the problem was not interstitial cystitis. And you see again how much of the nerve, instead of doing just a single nerve root, you actually can cover multiple nerve roots. You can have the retrograde down through the sacral nerves. You can have them antegrade back through the sacral hiatus and going out the sacral nerve roots. So just in conclusion, abdominal and pelvic pain are a significant cause of disability with multiple etiologies, and the interventional physician has an important role to play in the care of these patients.